I will be talking about an important subject that combines cardiology and neurology. Okay, why we have done that study? We can see quite a few complications of acute stroke, quite a few in the prolongation of the QTC interval. Is it related to the occurrence of acute stroke per se, or is it coexistent with something else, or is it just a sporadic occurrence? We should have asked ourselves these questions, why we didn't have. Okay, the cardiovascular complications are extremely common: ST segment, depression, elevation, ST segment changes, and so on, etc. There are several ECG changes following any type of ischemic stroke. However, the prolonged QTC interval represents the commonest one actually, the commonest one among them, and it is quite easily missed by many physicians and interns. Another point to highlight is that these ECG changes might be responsible for the sudden death in those populations. 86% of those patients of ischemic stroke will die eventually of a heart attack. Why? No, go to the other side. Okay. Yeah. Okay. Why such ECG changes would happen and will be happening in those populations? One of the theories is that dysautonomia might be responsible. The second is that the frontal lobe, insular cortex, amygdala, the stellate ganglia might play a role in the autonomic output of the brain that will eventually act on the cardiac myocyte system and the conduction system. Eventually, this will become the heart and the myocardium and its conductive system. All of them altogether become unstable and highly irritable, ending up with ventricular ectopic beats if we are lucky, which are very, very frequent. However, the most fearful complication is the torsades de pointes tachycardia at the outset of this QTC, a prolongation, which might degenerate eventually to VF and finally sudden death in someone with apparently small minor stroke. Okay, how we did it? It's obviously an observational study at the Shari General Teaching Hospital. طبعا هذه تابعة للبيشمركة، احنا ما تابعين لا للصحة ولا التعليم العالي. Altogether we have combined 100 consecutive patients with first ever ischemic stroke. We have to match them and gender match them without patient of a group of 100. Eventually we have gathered 200 cases. Meanwhile, we have to exclude those with a prior stroke of any type of traumatic brain injury, structural heart disease, cardiomyopathy, organ failure has to be out of the question. Treatment which affect the QTC interval, for example, anti-arrhythmic drugs, hypokalemia and hypocalcemia, and any acid-base imbalances. Of course, we do not deal with pediatric patients. Routine blood tests in general, brain imaging and brain MRI, depending on the timing of the patient when he or she Okay, we have reached into that slide, and the cornerstone of that study is the ECG data. We have done a single, just one, once in a while. 12-lead resting ECG, all patients at the time of their emergency department admission. QTc interval was measured manually by a single person from the onset of the QRS complex to the point at which the T wave ends. 3 to 5 beats were taken and altogether were averaged. Lead 2 was chosen because it was the most important one and the best one to calculate the QTc. The corrected QTc, of course, was then calculated using the Besset's formula. We did not use the automated ECG machines, which give a quantity of that acuity and QTc interval. The cutoff, of course, is the more than 45 milliseconds in men and 46 in female. Anything above that figure or these figures were considered abnormal by the study. What have we had? شوف لاحظ انه الغالبيه مع الافرج انه يعني it is more or less consistent with the age group that target stroke or stroke target that group of population, which is something in the late 60s to early 60s. Males outnumbered females. Okay. 90% were Kurds, Arabs were just about 9%. Of course, we still have many Arabs here, which might have other social factors and social demographic factors. The importance is that it's about 1/3. It's about 1/3 only. 1/3. All of the cases, just the cases, have had demonstrated a prolongation in the QTc intervals. Surprisingly, none of the controls gave us that number. At the end, the p-value was quite significant between the two groups. Okay, how about the presentation? The malactivities. طبعا الغالبية الجوية or the right-sided weakness. Left-sided weakness was a little bit lower. Other factors that are representations from 1, 2, 3, and 4. The majorities were represented with some kind of weakness, right-sided from grade 0 to grade 4. Okay, we tried to compare our findings with others, of course, outside our country and region and the Middle East. Age, gender, and ethnicity. All these three altogether were entirely non-significant, and that was consistent, of course, with other studies in 2005, 2006. Well, ethnicity, of course, 90% were Kurds from this area, and I have felt a little bit biased about that number. Anyhow, it's still consistent with those studies in 2006 and 5. طبعا واحد يسأل يقول ليش هذول من 2005 و 2006. هذيك الفترة كان الكونسنتريشن على ال QTc تقريبا from 2000 to 2010. Afterwards صار ال EP study more important. The role of ECG, a single ECG, was a little bit cancelled out from those studies. الجندر احنا سوينا study يعني دكتور هاوار أدنان ودكتور إيمان in 2014. It was consistent with our previous study. Still, it is inconsistent. And it is still non-significant with the gender. Laterality, right or left, between right and left side, of any kind of stroke, altogether, once again, they were non-significant and were entirely consistent with those studies. هي الفكرة مالتها شنو الQTc interval. احنا بدنا نتعامل ويا stroke is a vascular event. الفاسكولار ايفنت هنا ما شاء الله تارسين كل البيئات والطوارئ والخستخانات والعيادات. احنا كجماعه النيورولوجي خلاص انت تبابا عليهم خلاص ماكو عندهم في الباك جراوند بالكارديولوجي، ما عنده في الباك جراوند، ما عنده في الديساينينج، ما عنده في خلفيه بالكارديولوجي. انت لازم اسمك نيورو ميديسن، انت والتيم مالتك والسينيور هاوس اوفيسر مالتك حتى الجونيور هاوس اوفيسر. انت الاي سي جي is one of the cornerstone investigations in any vascular event. ما حد يركز، خلينا نقول الغالبيه لا يركزون، لا يشوفون، لا يبان عليه، مو شغلنا، او الكارديولوجي ما يصير احنا نشوفه ما ادري شنو، وبعدين بالاخير يصير لنا طلايب ويصير لنا طلايب. الفكره is quite easy, quite simple. ECG تقدر تحصله within 5 minutes in the ER all at once، تقدر تباعه تقرر اذا اكو بيه شيء، ما قدرت صاحبك ابو الباطنيه، كل سهل مو صعب. احنا هذا نشرناه، وانا كان دكتور اسو، الطالب مالتنا الدكتور عباس، ما اعرف جاي عباس اليوان، عباس ما جاي. المهم نشرناه وخلصناه، هذا اعتقد اني اقل من 10 دقائق بس. عندي حكايه واحده، استاذ خليل الشيخ لي يعني نايم شوي يعني تعبان. استاذ خليل الشيخ لي مثل ما قال كانت دكتور أسوع، كان لنا في الدور كلش مهم انه احنا نتاثر به خلقا واخلاقا قبل ما نتاثر به بالعلم. وانا واحد من الناس اللي كنت الطالب مالتي والسوبرفايزر مالتي، قلت له استاذ انا راح اسافر وراح اسافر خارج العراق واريد اجل البورد، يمكن اعوف البورد وما ارجع. قال لي روح بابا انت الله وياك والله يفتح ابوك، والله يديك الصحه والعافيه يا ربي وطولة العمر ان شاء الله استاذ، وتعلمنا منكم الخلق والاخلاق قبل ما نتعلم العلم، وخليتوا فينا فد بصمه تبقى طول العمر ان شاء الله، وطول العمر ان شاء الله يا رب.